Assalamu alaikum everyone. Welcome to our first lecture for FRCR2A and IMM. So today we will be discussing MRI brain basics, some important sequences, some special sequences, some anatomy overview, as well as neurodegenerative disorders. So the way I am trying to design the lectures is that we should be able to cover at least 4 to 8 questions that come up in the exam from the topic that we will be discussing. So this MRI brain basics is the I must say the crux of the whole MRI related questions in a way that mm, when you know the basic sequences, when you know the simple concepts like how the blood appears on the specific sequence, how metals alter the sequences and anatomy, you will be able to exclude or include a lot of differentials doing while attempting the exam. So I'm going to go into some very basic concepts that will help you in the exam definitely, because most of the questions in the exam are like you might have not seen those while practicing, you might have not read those in your crack the code or even in your big books, but if you know the basics and your concepts are very clear, crisp and strong, you will be able to get those. Okay, so do uh, go through these basics. Whatever region I start, I will always go through the basics of that system first, and then we will dive into the important hygiene topics. So from our MRI brain basics, inshallah, you will be able to cover some questions. And neurodegenerative disorders is unfortunately a topic that is not taught a lot. Most of the people avoid it. But in 2A and even in IMM and FCPS 2 exam, at least 3 to 4 questions are there, and in crack the code there are only 2 to 3 pages about this neurodegenerative disorders. But in the exam, the even if you are good with your basics, you might be able to attempt some questions that are not exactly written in the book, but I have excluded all the main concepts and the important points from certain which I actually saw in my exam. I attempted those with some my basic concepts and fortunately got those right. But when after the exam, when I started reading certain, I came to know that everything that I was being skeptical about in the exam, that I don't know where this line was written or where from this question is, all of those or most of those things are in the certain, but we are very short of time. I won't recommend that you start reading certain. If you have time till next year, you might. But for now, what I will be doing is that this is my job to go through all the important topics from the big books and make some notes, admit my lectures, and deliver those to you. So without any further delay, let's dive in. So in MRI brain, I will be going through the basic concepts, basic sequences, some important terminologies and special sequences and when to use those. This is very important. The in each and every FRCR2A exam, there are always 1 to 2 questions about sequence, and most of those sequences are new. Especially for those who are not actively reporting MRIs, these might be confusing. Okay, so this is our MRI brain's famous sequences. So what happens is that whenever you advise to do a simple MR brain, the important sequences that are included in each and every MRI brain plane are T1, T2, player, DWI and ADC, and GRE. These 5 sequences are must in any MRI brain plane. So if you order it with contrast, then we have T1 with contrast. And if you are doing some vascular imaging, then this is your MR-based vascular imaging, which would be your angiogram or your for dural sinuses, we have another sequence. And these are some specialized things which are fat suppression. perfusion imaging, spectroscopy, tractography, and some others as well that we will be discussing shortly. So this is the whole picture about them. Okay, now let's dive into the basic anatomy that we need to understand before reporting, before answering any question. First of all, I'll show you a CT. So you know that in our brain, there is a gray matter and there is a white matter. Gray matter is your cellular area, the neuronal cells, and the white matter is basically our axons. Okay, so on everything that is denser, that appears brighter on the CT, and everything that is hypodense, that has less cellular contents, is hypodense on the CT. Okay, for CT we use density, and for MRI we use intensity. So white matter includes myelinated axon tracts, contains fat, have a low density, and appears darker gray on CT. However, our gray matter, which is in the cerebral cortex or in the basal ganglia, that is the clump of cells. So that appears denser white. Okay. Now, okay, so this is the CT brain plane is good to detect blood. We know that, but it is we are handicapped in CT brain plane in many aspects. So we go to MRI. Okay. In MRI, there are two basic sequences that are crucial in each and every region's MRI, which is T1 and T2. For T1, keep it in your mind that T1 is for anatomy and T2 is for pathology or edema. These are two basic highlights that every radiology students must know. So what happens in T1? Actually, we know that T1 is good to show us fat, but we'll come to that later. For MRI brain, white is white and gray is gray on T1. What does it mean? It means that the white matter, let's go into some basic concepts. We know that axons are covered by myelin, which is fat. So fat appears whiter on T1. So white matter is white on T. However, the gray matter is actually the clump of the cells, and cells have water in the bodies. In the cell bodies, we have water. I'm just explaining in very simple layman language. I know you know the concept. So for remembering, for understanding, let's keep it simple. So gray matter is gray because it is less in fat, more in water. And axons are covered by fat. So that is your white matter. And that is whiter, that is brighter on T. So for T1, gray is gray, white is white. What happens in T2? Okay, so for T1, another thing. For T1, whenever we are giving contrast, the sequence that we acquire after giving contrast is T1. So whenever you see an image which is post contrast, that is T1 post contrast. Okay, do not confuse it. So why? Contrast material helps us to see masses. We know that contrast cannot get into normal brain and spine because of the blood-brain barrier. But masses do not have a blood-brain barrier. So when you give contrast, masses will take it up and light up, making them easier to see. So contrast will highlight, will make the masses bright. There you can see here that there is this was a very subtle mass on T1 without contrast image, but as soon as we gave the contrast, see this hyperintense lesion in the spinal cord. So this is how contrast works. The paramagnetic properties that I think you must have been through in your physics. Okay, now coming up to T2. For T2, remember H2O for water. T2 is for water and edema. Okay, so T2 shows you CSF, which is brighter, and edema, which is also fluid, that will also be brighter or hyperintense on T2. Everything bad is trying to turn your brain back into what it came from, water. This is for this concept is for someone who is very new into radiology, but even for understanding, it's good. So for T2 is for water, for edema, CSF edema, pathology, highlight on T2. Most of the tumors actually are hyperintense on T2 as well. Okay, next important friend of ours is DWI and ADC. In exam, there are going to be questions that are going to actually fry you on this concept. So keep your mind very sharp about DWI and ADC. What is that? DWI is basically diffusion weighted imaging. It means that what is diffusion? Diffusion measures how difficult it is for water to move around. Anything that makes it crowded and difficult for water to move around will be bright on diffusion imaging. So basically, DWI is showing you diffusion restriction in movement of water molecules. So anything that will disrupt water movement will make that area restricted for diffusion. I.e., we will be writing in our reports that diffusion restriction is positive or the lesion is showing diffusion restriction, etc. For strokes, DWI is very, 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 very important because whenever there is some infarction going on, as soon as the process starts, the earliest sequence that is able to detect stroke is DWI. It can detect an area starting to get infarcted within 30 minutes. Acute strokes are bright on DWI, but not all bright things on DWI are strong. We will discuss that as well. First of all, let's go to the basics again. So, what makes it difficult for water to move? Swollen cells, when there is stroke, what happens? When there is ischemia, blood supply is cut off. Cells run out of ATP, the sodium potassium pump stops working, and immediately water rushes in from osmotic pressure, and the cells swell. These swollen cells fill the interstitium and restrict the movement of water. That is why strokes are brighter on DWR. Okay. But other things that make it crowded and difficult for water to move as well. For example, tightly packed cells in aggressive tumor will also fill the spaces and make it difficult for water to move. It is trapped between the tumor cells. So highly cellular tumors are also bright on DWR. High-grade gliomas, medulloblastomas, these are also bright on DWR. So these are two things that you need to keep in mind, that if they say you in the exam that something is there which is brighter on DWI, then there are two phenomena that should be in your mind. Either it's stroke because the cells have swollen because of the restricted movement, water has moved into the interstitium, or the cellular load is so high that the water is unable to move because of very high number of cells in a certain area that is also restricting the water movements. Okay, next up. So this is a mass that is bright as stroke on diffusion. This is diffusion restriction, okay? And it is bright like stroke, but it is due to densely packed cells. First of all, we know that stroke is in the air territory that is being supplied by the certain artery that is being blocked during the stroke. And secondly, we know that mostly the tumors will show enhancement on the imaging. Stroke will not show this kind of enhancement. Secondly, on CT, the tumor is also very dense. We know, we have already discussed that anything that is tightly packed, whenever there is a group of cells that is tightly packed, that will be denser on the CT. So we have seen that. We can appreciate that here as well. That this is a dense lesion on CT. Then we did an MRI. We didn't do contrast in the first run. Okay, we did a brain plane, and I already told you that 5 sequences are must in any brain plane. So this brain plane had also had this DWI. We can see that there was diffusion restriction on DWI. Then we gave contrast, and here we can see that the mass is enhancing as well, avidly enhancing. So this is how we know that this diffusion restriction is due to a mass. Like clump cells are causing this diffusion. This is just an example for DWI. Coming up next, okay, one another thing that can make it difficult for blood to for water to move around is tightly clotted blood. Hematomas are also bright on DWI. In normal blood, water flows happily and freely, but once the clotting cascade starts, and fibrin and thrombin and whatever step happens in that clotting cascade is activated, the water is trapped in the clot interstitium. And then again, the water is trapped, differentiation is going to be positive. As you can see here, this is a CT brain plane that is showing you a hyperdense clot on CT. Hemorrhage is bright on CT because it is clotted. If you understand, the pathophysiology is same. The clotted blood is dense on CT because it's a clumped tissue, clumped blood cells. Same is happening on DWI. They are clumped blood cells, and these are restricted. These are showing restricted diffusion, as you can see here. Hemorrhage is right diffusion and as well as on the plain CT because the dense clot traps the water. Okay, so what next? Another thing that can restrict water to move is thick pus. This is very important. I'm trying to make your concepts that what are the possibilities if you are given a stem which shows that the diffusion restriction is positive. This is very important. Okay. So what is happening here? Thick pus, abscess formation. Whenever there is thick pus, it is thick and gooey, and you can just imagine how difficult it is going to be for water to travel through that gelatinous area of pus. Okay, so this is your pussy area. This is your abscess, and water cannot move here freely. So there is going to be diffusion restriction, but diffusion restriction is going to be inside the abscess. We all know that abscess is actually a ring enhancing lesion. Okay, so this is a ring enhancing lesion. There are some differentials about that, but let's have a basic concept about abscess, that it is a ring enhancing lesion. The ring is going to be smooth and relatively defined. There will be edema outside it. Edema will be in the masses as well, and there is contrast enhancement on the periphery. But let's suppose we haven't done the contrast imaging right now. We just did that typical 5-sequence MR brain plane, and on that we see the T2 is showing us a hyper intense area within the ringed lesion as well as outside, which is edema. And on the DWI imaging, you see that it is brighter internally. The central area of that ring lesion is showing diffusion restriction. From here, we know that it is actually pus that is making it difficult for water to move. Hence, this is restricted diffusion. And if you give contrast, there is going to be ring enhancement along the periphery, but not in the center. Pus will not enhance with contrast, but it will show restricted diffusion on DWI imaging. So this is your typical abscess. So this was our fourth thing that can show restricted diffusion. Coming up next is our next symptom. So we are done with restricted diffusion. Lastly, what we do is our gradient imaging. Okay. We will learn about ADC as well in the next slides. So the last sequence is your gradient sequence, which I told you that whenever you do brain plane, this is an important sequence to do. Some centers still do not do it, but this is important to know that if there is iron. Why is there iron? Iron is due to blood. So this is your gradient echo sequence, and this will show you these flow voids, these black areas, which are actually showing iron. Actually, gradient imaging is sensitive to metals. And what's important metal in the body that we know is iron, and iron is due to blood. Okay. So this gradient is basically to see iron or blood. Blood is black on gradient. I remember this here. This is a mnemonic for that. That metal is equal to blacksmith, and that is black on gradient. You can remember that easily without this as well. Coming up next, that what other metals can be black on gradient? Calcium. Calcium is in our bones and in other some lesions as well. So all that here is not gold. Not all that is black on gradient is blood. Other metals are black too, like calcium. So we need to differentiate that with other sequences, that either it's calcium or it's iron. Okay, so this is a brief introduction. We didn't discuss flare. What happens in flare? Flare is fluid attenuation recovery. CSF is suppressed in flare so that edema can be differentiated from the normal CSF. The main function of flare imaging is to differentiate edema from normal CSF, and flare can look similar to T1, but you can see that white matter is not white in flare. The white matter, gray matter sequence is going to be same as T2. Like we saw that the gray matter is going to be brighter and white matter is going to be darker on T2. Same will be happening in flare, but on T1, it's reversed. So this is how you differentiate between T1 and flare. And obviously, if there is edema, that is going to be very bright and white on flare, but not on T1. Edema is dark on T1. Okay, so let's see this gray-white junction. What is this gray-white junction? You know that this is your gray matter. We saw that. And this is our white matter. So, and this area is our subcortical white matter. And then we have these basal ganglia. This is our gray matter area, nuclei as well. So now coming up to T2, we can see that T2 and CT are similar in their color scheme. The gray matter is whiter and the white matter is black. Okay, these are some special MRI sequences. What is 3D phase? This is fast imaging employing steady state acquisition. This question in 2024 there was a question on this, that which sequence preferred to see cranial nerves, and the answer was this 3D phase. Okay, bright fluid signals, and this is actually used for cranial nerves and inner ears. There is another thing that is space. Sampling perfection with application optimized contrast using different flip angles evolutions. Space imaging is actually 3D. This is another 3D image. 3D turbo spin echo, and this is used for spine and joints. Then we have integrated imaging. We already saw that it was for blood. It's used for planning as VP contrast view of pain at heavily weighted T2 imaging, and this is done in the biliary tract. But and what is the importance of these sequences is that these are small part in all the disease, and you can reconstruct from that committed box so this and offers better contrast as well. High resolution imaging. T1 was actually disease. They asked the banks to do but with testing like that. Disease burden of something like that. That was this. Uh, uh, get let any data get. So, so in neuroimaging, in the Siemens machines, it's Bravo or 3D fast SPGR in G E in the Philips machine. Clinical uses measuring brain tissue loss in dementia, told you earlier. Try tracking Alzheimer's disease and creating 3D maps for robotic neurosurgery. And that imaging will you choose of these. Remember how contrast dynamic to deliver against the cross arterial Now we will be discussing some pathologies and then we will move on to neurodegenerative disease. So cytotoxic edema and vasogenic edema. This is the basic for understanding brain pathologies. So what happens is, what is cytotoxic edema? I know you might have already read that you have good hospital, but I want to revise that. Cytotoxic edema is basically due to in water, and water will come inside. But blood barrier is intact here. So the causes for cytotoxic is hypodense area along the right parietal region. We can see that here on the visible here. So I know that this is T2. And there is this signal area in the same territory. Now come hyperintense here. Here area for MCA blood supply, and this is in on flare. That is due to neoplasm, abscesses, trauma can also cause this, and hypertensive emergency. Why have vasogenic edema? Vasogenic edema is due to extracellular accumulation of the water in the brain. Disruption allows blood, plasma proteins, and fluid to leak out of the capillaries into the interstitial spaces of the brain tissue. And the key sign to remember is that it is going to show you these finger-like projections. These finger-like projections. Okay, so this is typical picture of vasogenic edema, and this was due to brain metastasis that can be seen here. So this is your subcortical T2 hyperintensity. Cortical ribbon is still intact here. In the infarcted tissue, this won't be visible, and this is your lesion that is causing this edema. Coming up next, let's differentiate again. This is your vasogenic edema. This is your cytotoxic edema. And the causes, again, location for cytotoxic is intracellular and for vasogenic is extracellular. Blood-brain barrier is disrupted in vasogenic edema, primary brain tissue, which is involved in cytotoxic edema both, but in vasogenic edema, predominantly white matter is involved. Core driver, the cause is it's cellular or ATP failure in the cytotoxic edema and capillary leakage in vasogenic edema. Primary treatment is restore oxygenation or perfusion in cytotoxic edema, and for vasogenic edema, corticosteroids. This was another question in the paper. In the exam, they asked that the patient is having multiple meds. I think the patient was of known case of CA breast, and there are multiple meds. What will you do as the first management step? So I thought that it should be radiotherapy, but it was not radiotherapy. It was actually corticosteroids. We will give steroid treatment as the first step of management to reduce the edema, and then we will move to radiotherapy. Okay? So this is an important thing because meds cause vasogenic edema. We know that. That's why I have included this table here. Okay. So another brief overview of what appears how on which sequence. First of all, we will discuss what is T2 hyperintense. So stroke is going to be T2 hyperintense, subacute hematoma, hydrocephalus, ischemic changes or inflammatory changes like in MS. Neoplasia, neoplasm masses can be T2 hyperintense, edema is T2 hyperintense, subacute hematoma, irons, and melanomas, and anything that is rich in protein will be T2 hyperintense. Now come up to some examples. We've already seen this, that infarcted tissue. Now this is the evil twin of DWI, which is called ADC. DWI, anything that is brighter on DWI, for it to be truly showing true restricted diffusion, ADC, the counterpart of DWI, should be black. So to confirm that if something is actually due to restricted diffusion, you have to visit ADC. You cannot give a verdict without reviewing ADC for restricted diffusion cases. Come up to this. This is another thing. T2 flare or shine through. So what is happening here? Something that anything that is DWI hyperintense is mostly hyperintense on flare as well. So you saw a thing that was flare hyperintense, that was hyperintense on DWI, but as soon as you moved on to ADC, it was not black. So this is not true diffusion restriction. This is called T2 slash flare shine through. And this is not due to stroke. These are the things that can cause T2 shine through. So true diffusion restriction is in acute. So this is your true scenario for diffusion restriction. But in subacute stroke, there is T2 shine through because DWI is going to be bright as well as ADC can be bright or normal. Epidermoid cysts are this is a very another common question. The epidermoid cysts show diffusion restriction, but those are also not dark on ADC map. Stress, edema due to vascular changes. That is sometimes also bright on DWI and also bright on ADC, which is another example for T2 shine through. So remember this table as well. This is another example that what things they are going to give you some scenario and they're gonna ask you that how this will appear on ADC. So you need to know that. Okay, so this is a case of brain metastasis. We can see that this is a hypointense lesion with the finger-like projected edema, and this actually is showing the importance of understanding gray-white matter junction and watershed area. So actually, Mets come up at the places which are basically gray-white matter junctions. So this is just an example to show you that. So what are the common cancers that give brain mets? So we have lung, we have breast, melanomas, renal, thyroid, and GIT tumors. Then what another thing that is T2 hyperintensive obstructive hydrocephalus, which will actually, so what is happening is that your water system is blocked. The water is going to seep through the pipes, through the leaks, wherever it can find its way, it's going to get out. So from here, this is called subependymal leakage or seepage. Though there is a lot of CSFs which is not finding its way to go out. That happens in obstructive hydrocephalus. So the CSF is leaking into the brain parenchyma, into the periventricular area. So that is also hyperintense on T2 and flare. Okay, this is a CSF actually, but it is hyperintense on flare. The concept here is actually this, that this is CSF, but if this is going to be flare hyperintense because it is not in its normal position. It's actually in the periventricular area. It shouldn't be. Then multiple sclerosis. This is an inflammatory lesion that is going to be T2 hyperintense. We are all very well aware of these Dawson fingers. These are seen in the parasagittal locations, and these are your Dawson fingers, ovoid lesions, hyperintense lesions, and these indicate active MS. So these are inflammatory lesions that are T2 and flare hyperintense. Then we have another thing which is called ischemic small vessel changes. This is just to show differentiation. These are more like periventricular seepage, but a bit irregular and clumped T2 hyperintensity. That is going to be ischemic small vessel change. This is also flare hyperintense. Then what appears hyperintense on T1? Paramagnetic substances, fat, protein-rich things, or subacute humidity. So these are few things that are T1 hyperintense or bright. So let's see that. This melanoma question is very famous. I think this was in both of my exams. So you have to know that melanoma is something that is T1 and T2 bright. So this is a T1 hyperintensity. Melanoma mets are similar. These are also T1 hyperintense. And any metal is going to be T1 hyperintense as well. So you can see T1 hyperintensities in the globus pallidi basal ganglia. And this is due to copper accumulation in Wilson's disease. So in Wilson's disease, basal ganglia will show hyperintensity, melanoma mets. They will have given you some history to understand either it's due to iron accumulation or due to mets or protein or fat to get you to the diagnosis whenever they're asking you about something that is T1 hyperintensity. Okay, then we have colloid cyst, which is well circumferenced T1 hyperintensity, which is actually due to protein rich mass. So colloid cysts are basically due to you can say that this is a protein lesion. So proteins are T1 hyperintense. So this is your colloid cyst. Then this is a very important table to learn. This is another exam question. What happens is that this is the age of the blood. You had a hemorrhage, you have a hematoma. So what happens is that hyperacute blood is going to be iso on T1 and bright on T2. Then it is going to be, even in the acute stage, within 1 to 2 days, it is again going to be iso, but on T2 it's going to be dark. Then in early subacute, within first week, that is going to be T1 bright and T2 dark. Late subacute, both bright and chronic, both dark. I have a mnemonic for this, IB, okay, IB, ID, BD, BB, DD. I think all of you must have been through that. I can share that in the group as well. So this is IB, ID, BD, IB, ID, BD, BB, DD. You can just learn that. Okay, so this is another picture for the same thing that we discussed, that in acute hemorrhage, this is going to be edema, this is iso, hematoma, and on T2, this is going to be dark and edema is going to be bright. Then in subacute, as we saw, that this is going to be BB, so this is your bright, bright. And then in the chronic stages, that is going to be dark, dark. Hemosiderin ring appears the chronic hematomas or hemorrhages. So that will actually make it darker. This brightened portion will be very less, and T1 will also show it as hypointensive area. So this is the chronic hematoma or hemorrhage. What happens on T2? Okay, so you have a lesion that is darker on T2. So what are the possible things? Protein-rich things. These are the things actually that were brighter on T1. These are now darker on T2. Protein, colloid cyst, we saw that. Flowing blood, I will show you that. Paramagnetic substances, we saw that iron, copper was T1 hyperintense, and that is going to be T2 hypointense. And then we have acute hematoma, we just saw that. Okay, flowing blood is the most important thing. Whenever you are reviewing the T2 image, you need to review all the vessels. Vessels have very fast flowing blood. So the gradients that we apply during the MR imaging will not affect the flowing blood, and that will all the normal flowing blood should be black on T2. But if there is absence of the flow void, these are called flow voids. So learn this terminology, that normal blood should be flow void. But if there is absence of flow void, it means that there is occlusion of the normal blood flow. So this was a thrombus, you can say. Okay, so this is absent right ACA flow void, and this is our thrombus. This is our case that is also in our neurodegenerative diseases. This is actually due to accumulation of iron. So iron is sitting up in the basal ganglia, and this is the famous eye of tiger sign. So we know that this is T2 hypo. This T2 hyper area is due to gliosis. The cell death is called gliosis. This is gliosis, but this whole basal ganglia is black. This is black due to iron accumulation. So the ferromagnetic substances are black on T2. Then what is dark on T1? Last thing, these are chronic lesions and fluid. We already discussed that edema is T2 white and T1 black. So edema is going to be T1 black. One important chronic lesion that you should remember is the dark or black holes of multiple sclerosis. These are actually the inactive multiple sclerotic lesions that are T1 hypointense. And these actually also tell you about the disease burden. So these are active lesions which were T2 hyperintense earlier, but now these are just sitting there, not active, not causing symptoms. Okay, so this is a brief summary for everything that we discussed, that what happens for T2, what happens for T1, and you can see that these are crossed more likely, more or less, these are like cross things, and this is the whole picture for bright and dark things on MRI T1 and T2. Okay, so let's come up to our main topic, which is a neurodegenerative disease. We have only 13 diseases to discuss. That is going to take up like 20 minutes. So let's quickly review these. I'll first show you the roadmap, that what you need to know about every neurodegenerative disease, because questions are going to be twisted about these concepts. Clinical diagnosis, predominant area involved, characteristic sign if there is any linked to that disease, which sequence demonstrates it best. This is the most seen question. There is a functional imaging view. Okay, so what are the diseases? First of all, there are some cognitive disorders, some movement and Parkinson related disorders. Then we have rapidly progressive neurodegenerative diseases and motor neuron degeneration. In these two, I have only included the most important ones, the Creutzfeldt-Jakob disease, the prion disease, and then in motor neuron degeneration, we have amyotrophic lateral sclerosis, ALS. But for these cognitive disorders, these are very important. The first three, four are the most important. Alzheimer's, frontotemporal lobar degeneration, dementia with Lewy bodies, limbic predominant age-associated TDP4 encephalopathy, we can call it late. Parkinson disease dementia, corticobasal degeneration, progressive supranuclear palsy. And then movement and Parkinson disorders, Parkinson disease, multiple system atrophy, progressive supranuclear palsy, corticobasal degeneration, again coming up here and here, Huntington disease, and neurodegeneration due to brain accumulation, iron accumulation. I have already shown you that, but we'll revise that here as well. Okay, so what happens in Alzheimer's? We all know that dementia, most common cause of dementia. So there must be a clue in the stem about dementia, episodic memory loss, followed by language and visuospatial dysfunction. The main pathology involved is amyloid beta plaques and tau neurofibrillary tangles. You don't need to remember this. And the important structures involved are medial temporal structures, particularly the hippocampus, the parahippocampal region, and entorhinal cortex. So this is the area that you need to remember. Medial temporal and hippocampal atrophy, classical early structural finding. Or with the passage of time, it will involve lateral temporoparietal cortex, precuneus, and posterior cingulate cortex. Here I am assuming that you know the anatomy, but if you don't, please spend some minutes and review the hippocampal anatomy. So this is the image that was asked in the exam. That three-dimensional T1 weighted magnetic imaging is the key structural sequence for assessing regional volume loss. And then PET scan can be done that will show characteristic temporoparietal posterior cingulate and precuneus hypometabolism, and amyloid and tau specific emission tomography can demonstrate corresponding pathological protein deposition as well. So this is the key thing to remember: progressive memory loss, hippocampal or medial temporal atrophy, temporoparietal atrophy, or hypometabolism, Alzheimer's disease. Severe hippocampal atrophy in a very elderly patient, old. Consider limbic predominant, the late disease. We will see that as well. So this is a case of that. You can see that here, even on this simple T1 image, that this was your normal hippocampus, and you can see that here that there is some volume loss of it. Okay, so this is showing us that there is atrophy of bilateral hippocampus. Okay, next is your frontotemporal lobar degeneration. The name tells you the disease. Frontotemporal lobar. Okay, but the frontal and temporal lobe both are involved. Important cause of early onset dementia. Early onset dementia. Now the age is important. They will tell you age in the stem. So if there is a patient with dementia, age is like in 30s or 40s, and initial presentation is about behavior, personality, or language dysfunction, you can see that these things will be coming up early in frontotemporal lobar degeneration, not like in Alzheimer's. Alzheimer's has these symptoms later. And the pathological group is again tau and TDP43 proteinopathies. You don't need to remember this. Characteristic involvement of the frontal and anterior temporal lobes. Atrophy may be markedly focal and asymmetric. Now, this is the key, that atrophy is going to be focal and asymmetric. in the frontal and temporal lobes. This severe cortical atrophy can produce knife-edge gyri. Knife-edge gyri means that gyri is going to be thinned out. Three-dimensional imaging is again your main structural sequence for MRI, and PET will also demonstrate frontal and anterior temporal hypometropy. So what you need to remember, early behavioral language disturbance, young patient, frontal and anterior temporal atrophy, that is frontotemporal lobar degeneration. If you remember the symptoms, even then you can diagnose the disease, even if you don't remember the radiology and everything. If there is a question about diagnosis, but these are less frequently asked, they actually twist the questions. Okay, so this is another table to differentiate Alzheimer's, memory predominant, hippocampal degeneration, temporoparietal later, and posterior cingulate involvement is key after hippocampus. Then we have frontotemporal, as I already told, behavior and language predominant, young patient, frontal and anterior temporal lobe involvement, and the frontal and anterior temporal hypometabolism. Hippocampus is not that involved. This is your case to have a look at that. You can see that frontal lobe is atrophic, and this is a similar picture to knife-edge gyri. Even the gyri can be more thin as compared to this as well. You can see that gyri are thinned out. This can be further thin as well. And this is your temporal lobe atrophy, and this is your frontal lobe atrophy. Behavior language first, frontal anterior temporal atrophy, frontotemporal lobar degeneration. Okay, next is your dementia with Lewy bodies. So for Lewy bodies, remember, this is going to be about visual area. Okay, so I remember it like this, that visual has L and Lewy has L. So visual. There should be a hint in the question about visual hallucinations or visual abnormalities. This is a pathology, alpha synucleopathy. You can ignore this. Core features include fluctuating cognition, recurrent visual hallucinations, Parkinsonism, rapid eye movement, sleep disorder, behavior disorder. Cognitive impairment occurs early in relation to Parkinson's symptoms. So actually what they're trying to tell you that in this disease, there is going to be cognitive impairment and there is going to be dementia, and there is even dementia is less. There is going to be actually Parkinson-like symptoms. We know that what is Parkinson is actually due to the Parkinson is basically your muscular issues, your abnormal tone, your abnormal movement disorders. These symptoms will appear in dementia with Lewy bodies. What is happening here in conventional MRI? It will show your preserved hippocampus, not like Alzheimer's. So hippocampus is preserved here. Because we can see that these symptoms are not related to hippocampus, right? What is happening here? This is your key, occipital and posterior cortical involvement. So what is happening in dementia with Lewy bodies? This is, okay, we all know that occipital is related to vision. Occipital lobe is related to vision, right? So we already discussed that Lewy is from visual. We are going to have some visual changes, and occipital and posterior cortex should be involved. That makes sense now, right? Visual changes, occipital lobe. Then we have that PET will also demonstrate occipital hypometabolism. Cingulate island sign. Okay, so what is happening? The cingulate cortex is actually the posterior most cortex that is a part of our limbic system. With this disease is not having any issues with limbic system. So this should be preserved. That cingulate island sign represents relative preservation of posterior cingulate metabolism as compared to its adjacent posterior cortical. We can do dopamine transporter SPECT imaging that will show reduced striatal uptake because of nigrostriatal dysfunction. That is actually the cause of Parkinson-like symptoms. Cardiac imaging can be done that will show reduced myocardial uptake as well because of sympathetic degeneration. Now they can give you any of these in the exam, or they can ask that this is the disease, what can be seen during the imaging. So any of these imaging patterns can be in the STEM, in the option. So the pattern that you need to know: visual hallucinations, fluctuating cognition, Parkinsonism, relative hippocampal preservation, occipital hypometabolism. That is your dementia with Lewy bodies. Major distinction is dementia before, around the onset of Parkinsonism is actually due to dementia with Lewy bodies. But Parkinson was already there, and then there was dementia. Then that is your Parkinson disease related dementia. So if dementia comes early with your visual and cognitive disorders, and Parkinson comes later or with that, then that is dementia with Lewy bodies. But if patient was already a diagnosed case of Parkinsonism and then he had dementia, that is Parkinson related dementia. That is not your primary Lewy body dementia. This is the PET imaging. This is your normal brain PET, okay? And you can see here, this is your Alzheimer's disease. And we can appreciate that there is hypometabolism in these areas, okay? Here. But in this disease, we can see this is your hypometabolism here. But in this disease, we can see that this area is preserved. Rather, there is hypometabolism in the occipital lobe areas, okay? So this is how we differentiate that this disease is actually due to occipital lobe involvement, not due to Alzheimer's. This is your cingulate gyrus. Okay, this is your cingulate gyrus. There is less uptake here, but in this Lewy body dementia, we can see that cingulate gyrus is preserved, but there is less uptake in the occipital lobe as compared to here. Coming up next is your limbic predominant age-associated TDP 43 encephalopathy, which is also called late. This is basically dementia, and it is the patient should be of very old age, okay, 70 plus, or even 80s in 80s. Affects the old, progressive amnesic dementia, closely mimic Alzheimer's. The protein is this. Imaging clue is disproportionately severe hippocampal atrophy. Disproportionately severe hippocampal atrophy, and it predominantly involves hippocampus and other limbic or mesial temporal structures. High resolution 3-dimensional T1 weighted MRI is most useful for demonstrating hippocampal volume loss. Alzheimer type amyloid pathology may exist, but negative amyloid imaging with mild hippocampal atrophy strongly supports its diagnosis. So you need to know that as well. If they give you a STEM and then mention that amyloid imaging is negative, then this is your answer, late disease. Very elderly patient, dementia, disproportionately severe hippocampal atrophy, negative amyloid imaging, that is your late. Alzheimer's disease, prehippocampal and temporoparietal pattern, but late disproportionate limbic and hippocampal pattern. Okay, Parkinson disease dementia, after Parkinson disease dementia, that comes after Parkinson symptoms. This temporal relationship is one of the most important diagnostic clues. Pathology is due to alpha-synuclein or Lewy body spectrum. Conventional MRI is non-specific. It's not helpful in Parkinson's disease. Dopamine receptor imaging demonstrates nigrostriatal dysfunction but cannot distinguish Parkinson's disease dementia from dementia with Lewy body, because nigrostriatal dysfunction will be present in both of these. More widespread cortical and subcortical atrophy may occur with disease progression. Established Parkinson, then came dementia. This is your Parkinson's disease dementia. And we already discussed that if dementia is first and Parkinson's symptoms later, that is your dementia with Lewy body. Okay, the last case here is corticobasal degeneration. That is a tau-associated neurodegenerative disease affecting both cortical and extrapyramidal symptoms. So symptoms are going involved are cortex and extrapyramidal. So sometimes are going to be according to that. Markedly asymmetric Parkinsonism, alien limb phenomena is very important. And then we have limb apraxia and cortical sensory abnormality indicating cortical involvement. Characteristic on imaging, you will see characteristic asymmetric cortical atrophy. One area of the cortex is more atrophic as compared to the other one. Predominantly, structures involved are perirolandic area, posterior frontal, and parietal. We need to learn that. Frontotemporal had anterior, parietal, and frontal. This has posterior frontal and parietal cortex. More affected cerebral hemisphere generally corresponds to the contralateral clinically affected limb. This is the alien limb. So if the right cortex is involved, the left limb will be alien limb. 3D T1 MR is the key structural sequence. Susceptibility sensitive imaging may demonstrate basal ganglia iron deposition. That can be seen as well. Dopamine receptor imaging may show reduced striatal uptake, but that is non-specific. So you can see that this reduced striatal uptake is present in a lot of diseases. In Parkinson's, in dementia with Lewy bodies, and even in hair. So this is a non-specific thing. So do not choose this in your question if they are asking about a specific imaging. So alien limb apraxia, markedly asymmetric Parkinsonism, and asymmetric perilytic atrophy is pure corticobasal degeneration. Let's have a look at the image. Okay, so this is your imaging showing the asymmetric atrophy of the cortical system. So we learned that that is going to be in the frontal and posterior parietal. We can see in the parietal and posterior frontal. So this is your parietal area that is involved, and this is asymmetric atrophy. This area is more involved. This is this. One-sided brain shrinkage, opposite hand effect, as I told you earlier. What next we have is progressive supranuclear palsy. This is again a tau-associated neurodegenerative disease. Saw that affects brainstem, basal ganglia, and cortical nectar. The important thing here is going to be your basal ganglia and brainstem. Okay, so all the diseases we have discussed so far didn't include brainstem or basal ganglia, and the characteristic clinical feature is vertical supranuclear gaze palsy, particularly impaired downward gaze. So if you see this symptom in your scenario, then the answer is progressive supranuclear palsy. And this comes up in the exam. Early unexplained falls are also characteristic. Axial rigidity and bradykinesia are common. Cognitive and executive dysfunction can. So midbrain atrophy is the key structure here. Okay, supranuclear palsy, we know that the area of the midbrain is involved. Your third and fourth and fifth and sixth nerves can be involved. So all third and fourth nerves are involved with gaze. So the symptoms will be about gaze. There is vertical supranuclear gaze palsy, and unexplained faults will also be there. Midbrain atrophy is present. Best demonstrated on sagittal T1 MR imaging. Remember this. Classic appearances, hummingbird or penguin sign. I'll show you that as well. Superior cerebellar peduncle atrophy can provide additional support, and PET will show midbrain, deep gray matter, and cortical hypometabolism. The symptoms: vertical gaze palsy, early falls, imaging, midbrain atrophy, hummingbird sign, cerebellar peduncle can also be involved. This is going to be progressive supranuclear palsy. Let's have a look at the image. This is your hummingbird sign. You can see that midbrain is atrophic, this giving this beak sign, and this is your healthy pons. Then again, the midbrain atrophy is giving this Mickey Mouse sign, and we have another sign. This one. This is your morning glory sign. What is morning glory? This is a cute, this purple flower. So midbrain tegmental atrophy on T2 imaging will appear as morning glory sign as well. You can see that the fluid is more than the midbrain volume. So this is indicating this glory sign, and this is your Mickey Mouse sign, and this is your hummingbird sign. So these three can be asked in some other fashion in the STEM to get you to the diagnosis of progressive supranuclear palsy. That will involve brainstem, that can involve basal ganglia and superior cerebellar peduncle. Now coming up to movement and Parkinson disorders, these are easy and some non-specific things. Parkinson we discussed, neurodegenerative disease that is linked to alpha-synuclein protein. Dopaminergic neurons are affected of the substantia nigra pars compacta, reduce dopamine input to the striatum. Bradykinesia, rigidity, resting tremors, famous signs. Conventional MRI can be normal, especially early in the disease. So what we do? We do susceptibility sensitive imaging. That will show you loss of normal nigrosome one swallowtail appearance. I will show you that. So what happens is swallowtail appearance is your normal appearance. That will be lost, and to see this appearance, we need a 3 Tesla MRI. You cannot see that this nigrosome swallowtail appearance on 1.5 Tesla. Dopamine transporter single photon SPECT imaging that will also show reduced striatal uptake, but we already discussed that this is a non-specific finding. Reduced uptake in the presynaptic nigrostriatal dysfunction rather than being specific. So we can see that there is no specific test for Parkinson. But if they ask you that what MRI sequence will help, this is your answer: susceptibility sensitive imaging. So symptoms will be typical Parkinson. There is a loss of nigrosome one swallowtail appearance on the 3 Tesla MR susceptibility weighted imaging, and that is the diagnosis of Parkinson's disease. So this is your bird with this swallowtail. This is called swallowtail. This is your normal nigrosome appearance on 3 Tesla MRI. This is one, this is two tail. Okay, so this is the nigrosome tail appearance. Okay, this is lost in the Parkinson disease. This is normal. They link to this one. Now let me show you the abnormal one. This is your abnormal one. You can see that there are these. This is like four appearance. Okay, there are two tones to this. But when there is loss of this swallow tail, you can see that there is no tail. This is loss of nigrosome swallow tail appearance. Okay. Normal nigrosome 1 contains a linear elliptical region of high signals surrounded by low signals in the substantia nigra on susceptibility weighted imaging, but there is loss of the swallow tail that supports your Parkinson. So this was the image for that. Now let's come to multiple system atrophy. This is again alpha synuclein associated degenerative disease. So what is extra here? Autonomic nervous system. There is basal ganglia involvement, there is cerebellum involvement, there is autonomic nervous, multiple system, basal ganglia, autonomic, and cerebellum. Predominantly with Parkinsonism or cerebellar dysfunction, early autonomic failure is a major clue. So you can see that symptoms will guide you to the answer. Early autonomic failure, orthostatic hypertension, urinary dysfunction, erectile dysfunction can. Pontocerebellar atrophy may occur. Middle cerebellar, we discussed in supranuclear palsy, midbrain, superior peduncle, multiple system atrophy, pontine, middle cerebellar peduncle. Putamen atrophy and signal abnormalities may occur in the Parkinson form, T2 weighted and flare. Characteristic hot cross bun sign. So to review hot cross bun sign in the pons, which is the characteristic sign for multiple system atrophy, you need T2 and flaring. Susceptibility sensitive imaging may demonstrate putamen iron related hyperintensity as well. So iron can be deposited in many diseases as well. Autonomic failure, Parkinson-like symptoms, cerebellar dysfunction, pontocerebellar abnormalities, hot cross bun sign, multiple system. This is your image. Another image, another sign to this disease is putamen rim sign. Lateral putamen T2 hyperintense rim. Okay, this is your lateral putamen T2 hyperintense rim. And in the pons, we can see that this is your hot cross bun. This is actually due to atrophy. Whenever there is atrophy, there is water. The cells are lost, replaced by water. So there is water, which is giving this characteristic hot cross bun sign. And you can see that here, that cerebellum is also atrophic. Here. So this is your atrophic sign and your hot cross bun sign and lateral putamen T2 hyperintensity. Then we have Huntington disease that is due to CAG trinucleotide repetition. It actually affects striatum. Chorea is the classic movement abnormality. They might mention chorea. Psychiatric manifestations will also be there and progressive cognitive impairment will be there. The key thing to remember in Huntington is your caudate atrophy. So Huntington, chorea, caudate. C for chorea, C for caudate. Chorea has H after C, H for Huntington. Remember that like this or any other mnemonic that you want to make. But Huntington, chorea, caudate. These are the three things that you need to remember. Atrophy produces enlargement of the frontal horn of the lateral ventricles. They will give box-like appearance. Early subtle caudate volume loss may be detected before even marked clinical disease. Later disease causes more widespread cerebral cortical atrophy. T1 is important. That will demonstrate caudate atrophy and ventricular enlargement. So T1 is good here. For chorea, psychiatric symptoms, caudate atrophy, box-like frontal horns, that is your Huntington disease. Let's have a look at an image. This is your Huntington disease. You can see this is your normal frontal horn. This is your normal caudate. Okay, we cannot see caudate and the frontal horns are quite enlarged, giving a box-like appearance. Coming up next, the second last, I think this is your iron-related disease. Okay, so there is iron accumulation. So what is happening? This is neurodegeneration due to brain iron accumulation, which is also known as PKNA, a difficult name due to enzyme abnormality. Things that you need to remember: globus pallidus. Globus pallidus is the most common basal ganglia involved. This is your typical eye of the tiger sign appearance, and this was the name PKNA is due to this. PCAN, pentothenate kinase associated neurodegeneration. What are the symptoms? Dystonia, Parkinsonism. Susceptibility is very important. That will show you iron. Low signal intensity. In the globus pallidus, we already discussed that iron is going to be T2 5. Too intense. Eye of the tiger sign due to central T2 hyperintensity due to gliosis. That is surrounded by low iron, low signal iron. And it is associated with this enzyme, but is not absolute pathognomonic. Always interpret basal ganglia iron in conjunction with the clinical phenotype and distribution of the susceptibility abnormality. So this is your thing to remember. Dystonia, globus pallidus, iron, eye of the tiger appearance. This is your neurodegeneration due to iron accumulation. So last two diseases. Prion disease, this is another very important disease that comes up in the exam. So this is due to prion, and this is transmissible spongiform encephalopathy. Unlike most degenerative dementias, the disease progresses rapidly, making the clinical tempo a major diagnostic clue. So if you are told that there is a disease that is very sorry fast to deteriorate, that is a clue to this disease. Rapidly progressive dementia, myoclonus ataxia, pyramidal and extrapyramidal signs may occur. What is the most important sequence to understand this disease? That is DWI. Cortical ribbing is actually due to restricted diffusion involving the cerebral cortex. Caudate and putamen may also demonstrate restricted diffusion. Corresponding ADC will show low signal confirming true diffusion restriction. Pulmonary sign is due to prominent posterior thalamic diffusion abnormality that is seen in one variant, and hockey stick sign is due to bilateral dorsomedial thalamic involvement. The thalamic involvement will show two signs, pulmonary and hockey stick sign. So what will be there in the stem? Rapidly progressive dementia, cortical ribbing on diffusion weighted imaging. That is your clue to Creutzfeldt-Jakob disease or prion disease. Sequence to remember, diffusion weighted and ADC. Do not confuse this with non-specific cortical flare signal intensity or cortical wave. So you can see that here. This is your cortical ribbing. This is diffusion restriction, okay? And this is your sign to show you the basal ganglia degeneration. And here you can see this hockey stick or pulmonary sign. The posterior thalami are involved. So this is your pulmonary hockey stick sign that is typical for Creutzfeldt-Jakob disease that also came up in my motor neuron degeneration. Last, amyotrophic lateral sclerosis. What happens here is degenerative disease involving both upper and lower motor neurons. Both upper and lower motor neurons. Symptoms are going to be similar to that. Actually, corticospinal tracts are involved, and lower motor neuron degeneration produces muscle wasting and fasciculations. We know that. So, upper motor signs are spasticity, hyperreflexia, and hypological reflexes. And lower motor signs are weakness, wasting, and fasciculation. Progressive motor weakness is the dominant presentation. Cognitive and behavioral impairment can occur in subset of patients, particularly when there is overlap with frontotemporal degeneration. T2 and FAIR are important. There is going to be hyperintensity along the corticospinal tracts. Abnormal signal may extend from the precentral motor cortex through the corona radiata and internal capsule. Posterior limb is important here into the brainstem. So signal abnormality can be very extensive. Precentral motor cortex, corona radiata, posterior limb of internal capsule, and brainstem. All of these areas can show hyperintensity. Precentral gyrus or motor cortex atrophy can occur, and MRI will support and is useful to exclude mimics. So this is not a typical diagnostic thing to do MRI here, but that will exclude a lot of differences. Upper and lower motor neuron signs and corticospinal tract, T2 or flare hyperintensity is your clue to amyotrophic lateral sclerosis. This is your thing. So you can see that this is your precentral motor cortex. This is T2 hyperintensity here. We can see hyperintensity in the corona radiata here. This is our motor cortex. This is our corona radiata. This is our internal capsule. And even there are hyperintensities in the brainstem. So these or any of these four can be present to diagnose a amyotrophic lateral sclerosis, and there will be symptoms of upper and motor neuronal disease. This is a chart summary for all of the things that we discussed. I can put this picture in the group as well. This is very important. At least if you cannot remember everything, remember these. And then this is another chart for all the signs that you need to remember. and why these signs are seen on the imaging. And lastly, I've included 5 practice questions. I'm very sure that after going through this lecture, you will be able to solve these. I will also put this in the group, and you should be able to know these now. And if you can't, reading the lecture and you're crack the core and you will be good to go. Now I want you to read all these diseases from your crack the core and also review starting sections of the brain system, because there are 21 sections for CNS in crack the core. So start slow, at least review this neurodegenerative portion and starting anatomy and some variants. And through the whole course, I will keep guiding you that what to review in which days, so that we can finish up all revising all of our high yield and even some low yield syllabus by mid October, inshallah. This is another question. This is another. I'm not expecting that you are going to solve this right now, because this is going to take you some time. So you can take a screenshot or whatever you like. And these are the answers, but I will reveal these later. Okay, so that is all from my side. I hope it was a bit beneficial. And this is a very, very, very important topic. So give it proper time. And I hope we will be good to go. If there is any question, you can ask. And otherwise, I'll end the meeting in 5 minutes. Okay, I think there are no questions. So let's turn it off and take care. Allah.